Hello everyone, my name's Lewis Hodder. I'm an advanced care paramedic working at Brisbane, Queensland. Today we're just going to be running through front of neck access.
So front of neck access is indicated for situations where you can't oxygenate, can't ventilate, or alternatively can't intubate. The goal of it is to establish an emergency airway, and it does this by directly communicating with the trachea via the cricothyroid membrane. It's not to be confused with tracheostomies and other surgical procedures for the neck. When talking about FONA, we also need to consider the complications. Hemorrhage, damage to surrounding structures are what we can cause, and also the predictors of a complicated surgical airway such as the mnemonic here, short.
So for the safety precautions for this scenario, we're going to have to wear a face mask, a mask with a filter, a gown, glasses and gloves, as well as adhering to the 5 moments of hand hygiene. For the purpose of this scenario, we will not be wearing all this equipment, however. For the setup for this procedure, I have the patient here, suction, airway adjuncts, including the 2 MPAs you see there ready to go. We have our ETT set up here. We have our SGA set up above. And here we have our surgical airway, including a size 6 ETT, scalpel, bougie, syringe with manometer, gauze if we need it as well. And all of these are in close proximity for the airway assistant to pass to the airway clinician. So where we're going to start in this scenario, we have pre-oxygenated and optimized our patient for induction for RSI. We've pushed the drugs and we are just still continuing our pre-oxygen phase. So from here I'm noticing apnea, loss of jaw tone. Pull the bag valve mask away and prepare for RSI. So as I'm trying to achieve a view, I move from right to left, sweeping the tongue, moving to the base of the tongue, trying to get into the vallecular groove. I can see the hard palate, soft palate, and uvula. And here, let's say I'm struggling to get a view. Now, from here, we could troubleshoot with the airway assistant helping with lip retraction. We could get our circulation assistant or even yourself to apply burp to rearrange those axes to improve your view. But for the sake of this scenario, we're going to say that this is a failed attempt. From here, what we can do, we can change the orientation of our patient. We can change their positioning, for example, and we can change clinician. From here, we could also change our MAC blade to a MAC 5. For the purpose of this, we're going to move through our vortex away from intubation and say we can't intubate, we can't achieve a view.
At this point, we need to verbalize we cannot intubate. We are moving towards our rescue airway.
From here, we did establish the bag valve mask was working, so we could go back to that. If our SATs, for my mind, are below 90%, I think it's probably a good option to go back to the bag valve mask first to try and reoxygenate a little bit.
It's important to mention our airway assessment, particularly pertaining to the components of a difficult airway with a supraglottic or a bag valve mask airway. This will inform our decision of which route to take regarding our failed airway algorithm.
Just because it worked before doesn't mean it's going to work again. And what we should do is to optimize as best we can for first chance success. So to do that, I'd recommend placing OPA double MPA and then using probably a 3-person technique. So that'll be a person at the front providing jaw tone as the circulation assistant, and then having the airway assistant squeeze the bag as you provide a form of 2-person technique on the mask. Remember, this is the skill, this is the difficulty. From here we can do a 1-person, and again we've failed. As a measure of success for our bag valve mask, we would be considering things like rise and fall, oscillation, ETCO2, tactile sensation of the bag, and hearing the sounds around the seal.
We've talked about the signs of failure, but we also need to talk about what attempt constitutes a good attempt for a bag valve mask. So we need to optimize the patient as we did in the video, and we also need to have no more than 6 ventilations and change something rapidly between them if they are failing. What we want to avoid is taking minutes on a skill that we know is going to fail after 20 seconds of good assessment.
So we're failing to bag valve mask our patient with our best attempt possible, in which case we're moving further down a vortex. We'll probably be approaching our SGA option. So from here we're going to remove these items, keep them close so we can use them again. And again, a lot of this will be passed by an airway clinician or an airway assistant. From here we're going to try and place our SGA, moving diagonally across the back of the tongue, trying to get it close to the lips. From here we will tape down prior to inflation to prevent displacement. And for this one, it is a size 4 for a 75 kilo male, so we can give a maximum of 45 mils, but for the purpose of this video, we're going to give 30. And again, we're going to try and ventilate for this patient, looking for rise and fall, ETCO2, sounds around the seal, and here you can hear it, the air escaping, tactile sensation of the bag is another measure of success, and auscultation. And also response, are we seeing an increase in SATs? Okay, at this point, we have a failed SGA, we've failed our bag valve mask, we've failed our intubation attempts. This is now a situation where we can't oxygenate, can't ventilate, an indication for our front of neck access.
There are a number of different types of front of neck access, including the use of proprietary devices and needle cricothoracotomy. For this example, we use surgical, which has the advantages of having a greater success rate. It's quicker, and it allows the attachment of the ETT tube to a ventilator to engage and create ventilation strategies. It's important to note Pacelli's law in regards to a size 6 ETT tube, which is much smaller than normal. Pacelli's law describes an exponential increase in resistance due to a decrease in radius size. Therefore, we need to consider this with our lung protection and ventilation strategies. Our first step is our setup. We should have our equipment ready and close. We should have marked our cricothyroid membrane, and unlike this patient, they should be getting ventilated with some O2 applied as well. The clinician performing the procedure should be lateral to the patient, near the monitor on the left of this screen.
The second step in our procedure is the identification of the site. So with a non-dominant hand, we should really stabilize from above this thyroid membrane or this thyroid cartilage. And in this man here, we can feel the laryngeal prominence, and then quickly we can fall down into this soft space, which is the cricothyroid membrane. Further down, we can identify our cricoid cartilage. Our third step in our procedure is the 8 to 10 centimeter incision through both the skin and the subcutaneous tissue. Be careful not to harm structures underneath. After this incision, being careful with the scalpel. This is a high risk for the clinician to injure themselves. We need to use our fingers and push through to identify the site. Now I can feel the cricothyroid membrane here between the hard thyroid cartilage and cricoid cartilage. Remember that this will be a blind procedure. There'll be a lot of blood. We may need suction with our assistant, as well as gauze potentially as well. But the clinician needs to be comfortable to do this without physically seeing or seeing the site. Our next step is our SIRT technique for the incision of the membrane itself. So we're going to stabilize the thyroid membrane, and with the blade facing towards you at the side, you're going to insert into the cricothyroid membrane and pulling and extending until resistance is felt. Then we're going to pull back and reverse. Then we're going to twist and traction the blade towards you, creating a triangular hole for insertion. From here, we're going to stabilize with a non-dominant hand and insert the bougie as perpendicular as possible to the ground. Obviously, I'm a bit limited here with the patient's head, and doing this as a single person officer. And then we're going to insert this bougie, trying to be certain that we're not going to create a false lumen until the 15 centimeter mark here. Now it's probably the most dangerous point in the procedure. We're going to retract the scalpel. Be careful not to harm ourselves. We're going to stabilize and have our offsider railroad our ETT tube over the top of the bougie. On the bougie insertion, we're going to probably require a twist to get insertion. It may be quite difficult until these ARC markings are around the skin, in which case we can stabilize, retract, inflate. Then we can inflate to 20 to 30 centimeters of H2O, like so. Then retract the bougie carefully for safety. From here, we would always make sure that we keep stabilized. We'll get the bag valve mask to confirm placement. Rise and fall of the chest, misting of the tube, end tidal CO2 being the gold standard. Rising sats and tactile sensation of the bag and sounds are how we're going to, as well as auscultation, is how we're going to measure our success for this procedure.
Although not specified in QAS guidelines, there are a number of options to secure the tube, including tape, and another really cool option is the suture, so suturing the skin around the tube and then connecting it and tying it to the tube. Another post consideration immediately after is hemorrhage control with direct pressure and gauze. Post-intubation cares also include ventilation, so I'd recommend connecting to a ventilator so we can perform some lung protective strategies as been specified above. Another consideration there is the ongoing management with paralysis with rocuronium and sedation as well. I would advocate for midazolam and fentanyl infusion. In regards to the goals of our infusion, we obviously have our dosages there, is to obviously avoid increases in stress shown through hypertension, tachycardia, rising EtCO2, tearing, and increases in awareness. For hemodynamic support, I'd recommend the use of sodium chloride 0.9% at initially 10 mils per kilo up to a total max of 20 mils per kilo, looking out for APO and other signs of fluid issues. For our vasopressor, I would recommend the use of a noradrenaline infusion. I've justified this in previous videos and the dosages are here listed. The goal of our vasopressor would be a MAP of 65. Thank you for taking the time to watch this video, and I hope it's been informative.